Good afternoon, everybody. I appreciate the invitation to come and speak. I'm actually formerly of Flagstaff. I got the crazy idea after living the good life for 5 years of private practice general surgery to go and become a fellow. And so now I'm in Tucson at University Medical Center, Tucson. It's a mouthful. So I wanted to choose a topic that was relevant to my institution. It's something that we've dealt with as well in Northern Arizona at Flagstaff, is we have some unique ways that we handle some of these patients from our referring facilities. And so I wanted to talk about the prevalence of traumatic brain injury, some of the types of injuries, and then really try to answer the question, does every TBI need to be seen by a neurosurgeon? And then discuss the brain injury guidelines which are present at our institution. And I certainly need to give a shout out to Dr. Joseph for helping me with this talk and his mentorship in this area as well. So like the topic said, I'm not actually really concerned about whether neurosurgeons sleep at night or not, but I am concerned about the utilization of the resources and trying to define and ask the question, do we need to admit these patients to the ICU, to the hospital? Do we need to spend the dollars that are associated with getting neurosurgeons to see these patients? Because as we'll talk about here shortly, neurosurgeons are kind of beat down, and there's not a whole lot of them around anymore. TBI is ubiquitous across the country. There's lots of people that die from traumatic brain injuries. There's over 1 million ED visits every year just for TBIs. The rate of TBI across the country as they present to the emergency room is increasing. This is looking over a decade-long period of time. 50% increase just in TBI alone. Deaths are actually decreasing, and I think this is a kind of a result of us just diagnosing TBI more frequently with our better CT scanners. Causes of TBI, if anybody's working in the trauma bay, we all know about the ground level falls, right? If you look at ground level falls, this is the red box here. Turns out right after you're born and right before you die, we fall a lot. And there's a lot of severe, significant injuries that occur from people having ground level falls. And the majority of our patients or a lot of patients in the elderly group, geriatric population, are on these novel anticoagulants, which makes it even worse. So this is a multidisciplinary conference. This is what makes this conference very nice. So I just want to talk about some of the hemorrhages that we're going to discuss in these guidelines, just so everybody's on the same page. This is a picture of a classic subdural hematoma, crescent-shaped. Blood gathers in the inner layer of the dura. This is the epidural hematoma, what it would look like. It's the classic lucid interval patient, usually an arterial injury. And then subarachnoid hemorrhage, this can be traumatic, and this can be an aneurysmal disease as well. This is how they look side by side. So also it's important to talk about the classification of these patients. This is good for research, but it's also good to put us all on the same page so we can know what category that we need to place these patients in so we know how to treat them. Mild is GCS 13 to 15, moderate GCS 9 to 12, and then severe is a GCS of less than 8. So how do we treat these patients? I mean, if you look at the standard therapy for primary traumatic brain injuries, right, when they sustain the injury and get to the hospital, there's not a whole lot that's changed. Certainly we have advances in preventing secondary brain injury, but there's medical therapy and there's surgical therapy, and there's not a whole lot that is new that's changed our management in a significant fashion over the last decade or so. But obviously this patient with a large subdural midline shift is going to be treated drastically different than this patient who, if you look closely, there's supposed to be a subarachnoid hemorrhage somewhere, although I certainly can't see it, and I'm sure many of you can't see it as well. This is from the National Trauma Database. If you look at the group of patients that had a head injury, over 200,000, the vast majority of them did not require an operation. Only 3.6% of these folks actually needed a neurosurgeon. So the management of these patients, it costs us billions of dollars a year. Most of these patients don't require surgical intervention, and so can we become more efficient in the way that we utilize our resources with hospitalization, ICU admission, and specifically neurosurgical consultation as well. If you look at the trends in the workforce and within the neurosurgical group, there's not enough supply for demand. There's about 3 to 400 jobs out there every year for neurosurgeons, and we only produce about 200 a year. There was a study that was done in the late 70s that told us how we should, or how many neurosurgeons we should train over the next 30 to 40 years, and it grossly underestimated the need of neurosurgeons. Their association says even, especially with us starting to cover more Americans for insurance, there's going to be a significant physician shortage. And as our population ages, this is going to increase exponentially. The other thing is not every neurosurgeon takes care of trauma patients. So for our trauma patients, only about 80% of the neurosurgeons that are out there even want to deal with them. So we have less than 4,000 neurosurgeons in the country. Population's 320 million. 25% of the U.S. population is in a county that does not have a neurosurgeon. And the demand for neurosurgeons is increasing as well. And again, only 80% of those neurosurgeons actually take call for trauma patients. This is where I used to work and where I still live, at least on weekends. And this looks at our geographical area. It's a very large area. There's Native American reservations there. The Grand Canyon's obviously there, which brings millions of visitors in every single year. And we have 2 neurosurgeons and 1 neurosurgical PA that takes care of all of these people. And their burden is quite high. And now certainly some of these patients go to Salt Lake and Vegas and down here to Phoenix, but that's a large geographical area and a lot of people to take care of for just 2 surgeons. So this is kind of an unfortunate title. We obviously know that neurosurgeons take very good care of our trauma patients, but the crux of this article looks at what does the people that provide care for the non-operative candidate for these TBIs, what's the perception out there that neurosurgeons are actually involved in their care? And the answer was only about 30% of people thought that neurosurgeons were even involved, and this makes sense. If I'm up in the middle of the night in Flagstaff and one of these kind of head bonks come in, GCS 14-15, very small bleed, we call the neurosurgeon, they say, yeah, look at the CT scan at home, go to the ICU, Q1 hour neuro checks, repeat CT scan in the morning. The neurosurgeon won't even see the patient until that repeat CT scan's been completed in the morning. They see a normal CT scan or a non-progression of the injury on the scan, see the patient, and they sign off, right? So the neurosurgeons really aren't the ones that are on the front lines taking care of most of these patients. And as a previous speaker said, the nurses are the ones really on the front line. The ICU nurses are who we rely upon in doing the examination, monitoring for changes in that neurological status, and then alerting the appropriate teams. This is a paper that looked at, is there any difference in the care or outcomes of patients depending upon what ICU they went to? They looked at mild traumatic brain injuries, and they took 500 patients and basically put, a third of them in a trauma ICU, a third of them in a neurosurgical ICU, and then let the neuro ICU neurologists take care of the other third. There's similar outcomes, no difference in morbidity and mortality, but the trauma ICU demonstrated a shorter length of stay and decrease the amount of CT scans that we got. This makes some sense just because we're the ones in the hospital seeing the patient in the ER, the trauma bay, and we are following the patient throughout. It turns out the neurosurgeons tend to agree with us. So retrospective review of 500 patients with mild TBI demonstrated no worsening of their clinical status or neurological status during their hospital stay. It's not to say they might have had a little bit of progression or flourishing of their bleeding on a CT scan, but it made no difference clinically. So the neurosurgeons even concluded that no neurosurgical consultation was required in those patients. So this brings me to the brain injury guidelines. And the hope is, or the goal is to standardize the care of these patients. It tries to answer the question, who needs a repeat CT scan, who needs ICU admission, hospital admission, who requires a neurosurgical consultation. With regards to the repeat CT scan, Dr. Ree, when he was at U of A, and the other members of the group published on this extensively. Basically, repeat CT scans are not needed for the vast majority of these patients. So here are the guidelines. We look at big 1, 2, and 3. The important thing to note is you have to satisfy each one of these variables to stay within the category. So if you satisfy all of the big 1 criteria, but yet you have a skull fracture, you have to immediately go then to a big 2. So you have to satisfy all of these. And then it looks at the therapeutic plan. So if you come in with a minor head bonk and your GCS is 15, maybe you don't even need to be admitted to the hospital. You get observed in the ER for 6 hours, and then you go home. Big 2, you will get admitted to the hospital for some neurochecks. There's no CT that's repeated in the morning and no neurosurgical consultation that's done. The big 3 are the patients that we're concerned about that may need an operative intervention. These are the patients that have an abnormal neurological examination or they have a significant injury, displaced skull fracture or a large bleed. If you look at the CAMP, these are people that are on any sort of anticoagulation, whether it be Coumadin, a novel therapeutic agent, or even an aspirin. Those patients automatically get bumped up to a big 2 or a big 3. Usually they're the wrong way. So if you look at, does this actually work? In terms of decreasing cost, this is a study that looked at the implementation and the results of the implementation at University of Arizona. 35% reduction in repeat head CTs, 20% reduction in neurosurgery consults, and then a third reduction in hospital costs. This is probably a very conservative estimate because it took about 8 to 10 months for this actually be fully implemented and to get buy-in from all the surgeons that were on board. There also is data that demonstrates that this is actually very safe. We're not causing harm to patients. In one study, there was, I think, 8 or 9 patients that did fail that criteria, but they failed because they were appropriately placed in the hospital, had a worsening of their status, got a repeat head CT scan, and then had appropriate therapies. So this does not mean that people get in the ICU, and if they have a deterioration, then we don't do something about that. So it is a very safe treatment protocol. So what about transfers? This is something that we've been interested in Flagstaff. I had nothing to do with this, but our neurosurgical group, as well as their PA, Rob Evans, and then our trauma coordinator, Bill Ashland, have worked a lot in having these agreements with outside hospitals and referring hospitals to say, hey, if you send us this patient, we're not even going to get a neurosurgical consultation, so leave them there. Call us on the phone, we'll look at your CT scan, we'll provide you support, and it's actually worked. We have a number of patients that don't come to our hospital every year because of this protocol, and hopefully some data with regards to that will be coming. Very labor intensive. This requires lots of trips to these places. It requires personal established relationships with these referring facilities, which can be difficult because some of these smaller areas have a lot of different doctors rotating in and out, especially on the reservation. A lot of docs come in, get their loans paid off, and then they leave. So you're dealing with different people. So it's an ongoing educational process. So in conclusion, the vast majority of TBI in this country that we deal with is non-operative. There's significant shortage of neurosurgeons, and we as acute care trauma surgeons have the ability and the skills necessary to manage the vast majority of these patients just fine. And the big guidelines are safe and certainly can lead to better utilization of resources. And I appreciate your time. Thank you.